Hello, my name is Yo Win. I'm the student pharmacist here at Sullivan University. I'm here to present a case. Patient came in with a chief complaint of having increased asthma symptoms. AA is a 27-year-old female with history of persistent asthma and generalized motor seizures controlled on topiramate, complaining of increased asthma symptoms but does not appear in acute distress. States she has daytime symptoms approximately 3 times per week. Uses her rescue inhaler 3 to 4 times per week, but not usually multiple times in a day, and is awakened by her symptoms approximately 1 time per week. Symptoms not tied to exertion alone. States good compliance to asthma medications and demonstrate proper inhaler technique. Patient wondering if a change in her asthma medication is needed. Her past medical history consists of persistent asthma, generalized motor seizures, family history none pertinent, social history she denies smoking, former smoker, she denies recent alcohol, former smoker, quit 3 years ago, law student. Medication allergy, she's allergic to gabapentin. Allergic reaction is edema, and she's also on topiramate, fluticasone, albuterol, trospirentex. Immunizations are all up to date. Physical findings: positive, increased asthma symptoms, mild wheezing, no acute distress presently. Vitals include her blood pressure to be 110/72, heart rate 90, Tmax 36.8, respiratory breaths per minute it's 18, height 69, weight 158, BMI 23.3. Laboratory data: we're going to move on to the assessment. The problem is uncontrolled persistent asthma, evidence of problem and rationale for the chosen plan. She's wheezing. She met 3 of the uncontrolled asthma symptoms. Daytime asthma symptoms 3 times a week using SABA reliever 3 to 4 times a week. Patient experienced nighttime awakenings. Determined patient's current place in therapy to be step 2, low dose maintenance controller. According to the 2022 GINA, with current symptoms and status of the patient needs to progress to step 3 therapy for asthma maintenance in adults, which includes low dose maintenance, intracortical steroid, and LABA. We're going to initiate Symbicort as maintenance and reliever therapy. And we're going to discontinue the fluticasone and the albuterol. And goal sort of problem is to relieve uncontrolled persistent asthma and symptoms, prevent asthma-related exacerbations, improve patients' quality of life. Drug regimen: we're going to initiate Symbicort 80, 84.5. The route's inhalation, so you're going to inhale 2 puffs into the lungs, BID for persistent symptoms. May administer up to 2 inhalations every 20 minutes for 3 doses as needed. A max of 12 inhalations per day. Duration is indefinitely. And we're going to monitor thrush and upper respiratory tract infections with this drug. And efficacy: patients should see clinical improvements in respiration, wheezing, and FEV1. Follow up with the patient in 1 to 2 weeks to see how patient is doing. Consider stepping down in therapy when asthma is well controlled, once it's been maintained for about 2 to 3 months. And that is it.